Sally arrives at the clinical office for a routine prenatal appointment. She becomes red in the face as she states that lately she has been craving and ingesting dirt. Which of the following is the most appropriate response from the nurse? A. You must be admitted to the hospital. B. Do you have a history of psychiatric illness? C. You must stop immediately. D. Where have you been obtaining the dirt that you're ingesting? E. Why would you eat dirt? The answer is D. Where have you been obtaining the dirt that you're ingesting? During pregnancy, many women crave and eat substances that adults do not generally ingest. This condition is normal and is called pica. Often, the substances do not have high nutritional value. Examples are dirt, chalk, rocks, toothpaste, toilet paper, etc. It is important to determine the risks involved with ingesting these materials. For example, the nurse must determine that a woman who is eating dirt does not ingest potting soil mixed with fertilizer and other potentially toxic chemicals. Your patient is under 24-hour fetal monitoring and observation. The fetal monitoring strip begins to show decelerations, starting after the peak of contractions and recovering late. Which of the following interventions does the nurse anticipate doing? A. Administering medication. B. Reposition mother. C. Fluid bolus with normal saline, NS. D. Removing oxygen supplementation. E. Increasing rate of oxytocin. The answer is B. Reposition mother. Late decelerations are caused by uteroplacental insufficiency. The nurse should anticipate many interventions to promote uteroplacental blood flow. Initially, the nurse should implement oxygen supplementation, stop the oxytocin infusion, reposition the mother to the left side, and introduce a fluid bolus of lactated Ringer's solution, LR. The nurse is reviewing a fetal monitoring strip. Decelerations are onset with the beginning of each contraction and recover at the end of each contraction. Which type of deceleration is this, and why does it occur? A. Variable decelerations, umbilical cord compression. B. Late decelerations, uteroplacental insufficiency. C. Early decelerations, head compression. D. Variable decelerations, head compression. E. Early decelerations, uteroplacental insufficiency. The answer is C. Early decelerations, head compression. A fetal heart rate, FHR, deceleration occurs when the FHR drops 15 bpm below baseline for a period of 15 seconds when the gestation is more than 32 weeks and 10 bpm below baseline for 10 seconds when gestation is less than 32 weeks. When the onset of the deceleration occurs at the onset of a new contraction and recovers with the end of the same contraction, the strip is demonstrating early decelerations, and the fetus is exhibiting head compression. Late decelerations occur when the deceleration begins after the start of a contraction and does not resolve until after the contraction has finished. Late decelerations are the result of uteroplacental insufficiency. A variable deceleration is caused by cord compression, and appears as a brief drop in FHR from baseline then resolves quickly, creating a V shape on the strip. Which of the following describes a Category 2 fetal heart rate, FHR, tracing? A. Baseline 100 bpm, absent variability, 1 acceleration, prolonged decelerations. B. Baseline FHR 170 bpm, moderate variability, 2 accelerations, 0 decelerations. C. Baseline FHR 100 bpm, minimal variability, 0 accelerations, variable decelerations. D. Baseline FHR 145 bpm, moderate variability, 2 accelerations, 0 decelerations. E. Baseline FHR 90 bpm, marked variability, 0 accelerations, late decelerations. The answer is C. Baseline FHR 100 bpm, minimal variability, 0 accelerations, variable decelerations. A Category 2 fetal heart rate tracing include all FHR tracings that are not Category I or Category 3. Category 1 FHR tracings are as follows: baseline 110 to 160 bpm, moderate variability, absent late or variable decelerations, present or absent early decelerations, and present or absent accelerations. Category 3 FHR tracings are as follows: absent baseline FHR variability, recurrent late decelerations, recurrent variable decelerations, bradycardia, and sinusoidal patterns. Which of the following is not a risk factor for gestational diabetes? A. Obesity. B. Poor diet. C. Previous stillbirth. D. Previous macrosomic infant. E. Family history of diabetes. The answer is B. Poor diet. Risk factors for gestational diabetes include obesity, family history of diabetes, history of gestational diabetes, hypertension, preeclampsia/eclampsia, recurrent urinary tract infections, vaginitis, polyhydramnios, previous large infants, 9 pounds or greater than 4,000 grams, glycosuria or proteinuria on 2 or more occasions. While poor diet may contribute to diabetic concerns, it is not directly associated with a higher risk of gestation diabetes as the other risk factors are. During the prenatal period, nurses are responsible for educating their patients on all of these risk factors as well as a proper prenatal diet. The nurse is observing the fetal monitoring strip of a 37-week-old fetus. He observes a visually apparent and abrupt increase in fetal heart rate, FHR, from a baseline of 140 to a peak of 159. The FHR returns to baseline after 20 seconds. What type of fetal heart rate characteristic has occurred? A. Deceleration. B. Recurrent acceleration. C. Prolonged acceleration. D. Acceleration. E. Tachycardia. The answer is D. Acceleration. An acceleration in fetal heart rate is defined as a visually apparent and abrupt increase in FHR, where the FHR increases from the onset of the acceleration to the peak in less than 30 seconds. At less than 32 weeks, the acceleration must peak at least 10 bpm above baseline and last at least 10 seconds. At more than 32 weeks, the acceleration must peak at least 15 bpm above baseline and last at least 15 seconds. A prolonged acceleration follows the same guidelines as an acceleration, but lasts more than 2 minutes and is not longer than 10 minutes in duration. After 10 minutes, it is a change in baseline FHR. A deceleration is a visually apparent decrease in FHR from the baseline, gradual or abrupt, that returns to the original baseline. Recurrent accelerations occur with more than 50% of contracts in any 20-minute window. Tachycardia is a baseline FHR of more than 160 bpm. The nurse observes an electronic fetal monitoring strip. Upon review, the fetal heart rate, FHR, undulates from 140 bpm to 160 bpm and back down to 140 bpm in a consistent cycle over a period of 35 minutes. What type of fetal heart rate characteristic is occurring on this electronic fetal monitoring strip? A. Intermittent. B. Variable. C. Bradycardia. D. Recurrent. E. Sinusoidal. The answer is E. Sinusoidal. A sinusoidal pattern is a visually apparent, smooth, sine wave-like undulating pattern in fetal heart rate baseline with a cycle frequency of at least 3 to 5 minutes that persists for more than 20 minutes. Variable describes an abrupt deceleration of visually apparent decrease and return in fetal heart rate, FHR, from baseline lasting less than 30 seconds. Bradycardia occurs when the baseline FHR is less than 110 bpm. Intermittent describes an acceleration or deceleration occurring with less than 50% of contractions in any 20-minute window. Recurrent describes an acceleration or deceleration occurring with more than 50% of contractions in any 20-minute window. In a fetus positioned at left occiput anterior, LOA, where should the nurse assess the fetal heart rate, FHR? A. Above umbilicus on mother's right side. B. Below umbilicus on mother's right side. C. Above umbilicus on mother's left side. D. Below umbilicus on mother's left side. E. At level of umbilicus. The answer is D. Below umbilicus on mother's left side. When considering where to hear fetal heart rate best, the nurse must consider the location of the fetal back. Weeks gestation or size may also affect the location of the best place to assess fetal heart rate. LOA, or left occiput anterior, is the most common fetal lie. A fetus in LOA is in vertex presentation with the fetal occiput on the mother's left side toward the front of her pelvis. In LOA, the FHR is best heard below the umbilicus on the mother's left side. In LOP, left occiput posterior, the FHR is best heard on the mother's left side at the level of the umbilicus. In ROA, right occiput anterior, the mother's right side below the umbilicus. In ROP, right occiput posterior, the mother's right side at the level of the umbilicus. In LSA, left sacrum anterior, the mother's left side above the umbilicus. In RSA, right sacrum anterior, the mother's right side above the umbilicus. What is the triad of presenting symptoms with endometriosis? A. Dysmenorrhea, infertility, and dyspareunia. B. Dysmenorrhea, metorrhagia, and dysuria. C. Hirsutism, infertility, and oligomenorrhea. D. Menorrhagia, infertility, and dyspareunia. The answer is A. Dysmenorrhea, infertility, and dyspareunia. The triad of presenting symptoms for endometriosis is dysmenorrhea, painful menses, infertility, and dyspareunia, pain on sexual intercourse. The most common presenting symptom is extreme, intense uterine cramps which may radiate to the back or down the thighs. Endometriosis is also a common cause of infertility due to a local paracrine effect. Pain on intercourse may be due to the implantation of endometrial cells in the vagina or the area around the cervix. Endometriosis will not necessarily result in menorrhagia, or excessively heavy bleeding. Hirsutism, infertility, and oligomenorrhea are symptoms commonly seen in polycystic ovarian syndrome, PCOS, rather than endometriosis. Which of the following increase the risk of endometriosis? A. Lack of exercise. B. Presence of an intrauterine device, IUD. C. Family history of endometriosis. D. All of these are correct. The answer is D. All of these are correct. The incidence of endometriosis increases significantly in individuals with a family history of the condition. Other contributing factors are sedentary lifestyle, lack of exercise, presence of an intrauterine device, a diet high in fat, the presence of estrogen dominance, and liver dysfunction, due to decreased estrogen metabolism. Which of the following is a possible cause of vaginal bleeding in early pregnancy? A. Trophoblastic disease. B. Spontaneous abortion, miscarriage. C. Cervical ectropion. D. All of these are correct. The answer is D. All of these are correct. All of these could be possible reasons for bleeding in early pregnancy, including physiologic or implantation bleeding. Bleeding may indicate threatened miscarriage or other serious condition, or it may simply be due to the implantation of the embryo into the endometrium. Which of the following terms denotes a menstrual cycle that is irregular, of shorter duration than normal, and of excessive volume or duration? A. Amenorrhea. B. Metrorrhagia. C. Menometrorrhagia. D. Oligomenorrhea. The answer is C. Menometrorrhagia. Menometrorrhagia is a term used to describe a menstrual cycle that is irregular, of shorter duration than normal, and of excessive volume or duration. Amenorrhea is the absence of a menstrual cycle. Metrorrhagia is a term for a menstrual cycle that is of normal flow duration and volume, but which is irregular and has a shorter than normal cycle length. Oligomenorrhea describes a menstrual cycle that is longer than 35 days, often characterized by a prolonged follicular phase. Pregnant individuals with gestational hypertension, proteinuria, and signs of liver or kidney dysfunction should be evaluated for what potentially life-threatening condition? A. Gestational diabetes. B. Placenta previa. C. Ectopic pregnancy. D. Preeclampsia. The answer is D. Preeclampsia. Preeclampsia is a potentially life-threatening disorder that generally includes gestational hypertension, proteinuria, edema, red blood cell dysfunction, and signs of liver or kidney dysfunction. It is more common in weeks 32 to 40 and develops in 2 to 8% of pregnancies worldwide. At what point does preeclampsia develop into eclampsia? A. At the initiation of kidney failure. B. At the progression into seizures. C. When there is evidence of vascular dysregulation. D. When blood pressure exceeds 160/95 mm of mercury. The answer is B. At the progression into seizures. Preeclampsia develops into eclampsia at the onset of seizures. Seizures are tonic-clonic and may appear during pregnancy, during labor, or postpartum. It is relatively rare, affecting only approximately 1.2 to 1.8% of pregnancies. What is the most common time for miscarriages to occur? A. 0 to 12 weeks. B. 12 to 20 weeks. C. 16 to 24 weeks. D. 22 to 28 weeks. The answer is A. 0 to 12 weeks. The most common time for miscarriage to occur is during the first trimester, between 8 and 12 weeks. This may even occur before an individual is aware that they are pregnant. Chromosomal abnormalities are identified in approximately 50% of first trimester miscarriages, while later miscarriages may be more likely in individuals with uterine malformations or cervical incompetence. Which of the following is a risk for preeclampsia? A. Diabetes. B. History of hypertension. C. Primigravida. D. All of these. The answer is D. All of these. There are several risk factors for preeclampsia. These include history of hypertension, diabetes, older maternal age, first-time pregnancies, primigravida, and pregnancies with twins or multiples. A labor and delivery nurse is assessing a newborn infant and notes that the infant appears to be jaundiced. What is a possible cause for this condition? A. The baby has been born HIV positive, as the mother was unable to afford HIV medications. B. The mother's blood is Rh negative and gave birth to her second Rh positive child without receiving RAGAM during the pregnancy. C. The infant is experiencing fetal alcohol syndrome, as the mother admitted to utilizing drugs and alcohol throughout the pregnancy. D. The mother had gestational diabetes causing jaundice of the infant. E. The mother has exposed the infant to an active genital herpes outbreak. The answer is B. The mother's blood is Rh negative and gave birth to her second Rh positive child without receiving RAGAM during the pregnancy. Jaundice of a newborn may be either pathologic or physiologic. Pathologic jaundice is usually the result of Rh incompatibility between the mother and the fetus. It occurs during a subsequent birth after the mother's blood has been exposed to the infant's blood during the first birth. RAGAM is given to the mother to prevent her immune system from attacking the second fetus, causing erythroblastosis fetalis and subsequent pathological jaundice. A labor and delivery nurse is monitoring a client in active labor after receiving epidural anesthetic. Upon assessing the client, she notes that the patient's blood pressure has fallen to 95/75 mm of mercury. The nurse's first action should be: A. Obtain an ECG. B. Give 1 mg epinephrine. C. Contact the physician immediately. D. Increase IV fluids. E. Place in semi-Fowler's position. The answer is D. Increase IV fluids. The first action should be to increase fluids, place on their left side and give oxygen. It is not necessary to contact the physician until all nursing interventions have failed. Epinephrine, a vasopressor, should be reserved for emergent situations only. A 26-year-old female primigravida presents to the clinic to discuss her estimated date of birth, EDB. The nurse records the client's first day of her last menstrual period as February 28, 2015. What would be her EDB? A. December 6, 2015. B. December 5, 2015. C. November 5, 2015. D. December 7, 2015. E. November 28, 2015. The answer is B. December 5, 2015. The calculation of an estimated date of birth requires applying Nclex rule, where once determining the first day of the client's last menstrual period, subtract 3 months and add 7 days and 1 year. The labor and delivery nurse is caring for a pregnant client that is experiencing contractions and has been on an external tokadynamometer to measure fetal heart tones as well as uterine contractions. The nurse notes that there are decreases in the fetal heart rate at different times of a contraction. The nurse is aware that this type of finding is consistent with variable decelerations, which are indicative of which of the following: an uteroplacental insufficiency. B. The effects of decreased pitocin infusion. C. A prolapsed umbilical cord or knuckle cord. D. The third stage of labor. E. Fetal head compression during contraction. The answer is C. A prolapsed umbilical cord or knuckle cord. Variable decelerations can occur at any time during a contraction, or without a contraction. They are caused by the umbilical cord that is prolapsed or wrapped around the fetal neck, also known as a knuckle cord. The compression of the cord can ultimately lead to fetal hypoxia, and therefore an intervention will be required to alleviate the compression. A 24-year-old primigravida client has just given birth to a Rh-positive child and she herself is Rh-negative. The nurse recognizes this situation can lead to future problems in terms of future pregnancies due to this blood type mismatch. All of the following are associated with Rh factor incompatibility except dash. A. May lead to fetal anemia and lead to an acceleration of red blood cell production if the mother is not given Rho, D immune globulin to prevent antibodies from destroying fetal blood cells. B. The mother will form IgG and IgM antibodies in response to being exposed to a fetus incompatible blood type. C. A major effect of Rh incompatibility is an increased risk of blood clotting and thrombosis in the fetus during subsequent pregnancies. D. The mixing of fetal blood with maternal blood may occur during an amniocentesis or early separation of placenta during birth. E. Kernicterus is a potentially serious effect due to pathological jaundice that can have long-lasting neurological effects on the child if not prevented. The answer is C. A major effect of Rh incompatibility is an increased risk of blood clotting and thrombosis in the fetus during subsequent pregnancies. Blood clots are not a common effect in the fetus due to Rh incompatibility. A disorder known as erythroblastosis fetalis is a type of hemolytic disease that occurs in the fetus due to an immune reaction of the Rh-negative mother in an Rh-positive fetus. All other choices are associated with this type of incompatibility. Which type of abortion is associated with sepsis, cramping, abdominal tenderness and an open cervical loss? A. Threatened abortion. B. Spontaneous abortion. C. Inevitable abortion. D. Complete abortion. E. Missed abortion. The answer is E. Missed abortion. A missed abortion is marked by the death of the fetus in utero but is not expelled from the uterus. If left untreated, can lead to infection in the womb. It is marked by foul odor and bleeding as well as an elevated temperature and sepsis. Which of the following statements is true about a high-data-deformed molar pregnancy? A. A molar pregnancy is a type of ectopic pregnancy in need of dilation and curettage to prevent internal hemorrhaging or possible hysterectomy. B. An ultrasound usually reveals a mass resembling a cluster of grapes, and a blood test will reveal a positive pregnancy result due to elevated HCG, human chorionic gonadotropin, hormone. C. The cause of a molar pregnancy is due multiple ovum becoming fertilized and coalescing to form a cluster of atypical cells containing a haploid number of chromosomes. D. A molar pregnancy can proceed without incident once Rhod immune globulin is administered to the E. A high data to form molar pregnancy is reported to cause malignancy in approximately 60% of cases. The answer is B. An ultrasound usually reveals a mass resembling a cluster of grapes, and a blood test will reveal a positive pregnancy result due to elevated HCG, human chorionic gonadotropin, hormone. A high data to form molar pregnancy is mostly a benign process that may occur due to an abnormal ovum becoming fertilized and growing into collection of cells in a cluster-like formation. They are benign over 80% of the time. Rhod immune globulin is a medication administered to an Rh-negative mother that will give birth to a second Rh-positive child to prevent an immune reaction that may harm the child. A woman is hospitalized for preeclampsia. Which medication may the nurse administer to prevent the occurrence of seizures? A. Calcium gluconate. B. Zolpidem. C. Pitocin. D. Nubane. E. Magnesium sulfate. The answer is E. Magnesium sulfate. Magnesium sulfate is used to prevent seizures in women with severe preeclampsia. Calcium gluconate is the antidote if magnesium toxicity is assessed. It should be readily available when a woman is receiving magnesium sulfate. Pitocin is used to stimulate the uterus, often to induce labor. Nubane is an opioid that can be given to women during labor to treat pain. Zolpidem, Ambien, is a sleep aid. Jean is a 33-year-old woman who has previously had regular periods but has not gotten her period for 6 months. Which of the following would the nurse rule out as the cause? A. Cross-country running 5 times per week. B. Poor eating habits. C. Yoga once per week. D. Kidney disease. E. Antidepressant use. The answer is C. Yoga once per week. Yoga once per week, light exercise, is the least likely of the above to cause a change in regular menstruation. Cross-country or long-distance running, vigorous exercise, is more likely to cause changes to a woman's cycle. Poor lifestyle choices such as eating habits and health issues such as kidney disease can also cause irregular menstruation. Likewise, pharmaceuticals can have the same effect.